thing. So I find the ASIS. I'm going to slowly dive in at an angle, just like that. Let me know if it's painful, okay? So I'm going to dive in at the angle till I'm in the neighborhood, and then from here I confirm with hip flexion. So can you?
Get a better palpation. And so the first thing I'm going to do is find the ASIS, right? Easiest point to find on the pelvis. As I move straight inferior, so down towards the knee, I run into nothing for a little bit, right? That empty space there. And now I'm going to come medial, and then you're going to feel the pubic bone, right? And so from there, what do I have to do to get over the anterior part of the femur? Yeah, just a little lateral inferior. Just going to drop right underneath that pubic bone. ASIS. I'm going to come down into that soft tissue spot right here. All right, so I'm just going underneath. I'm going to come in until I find the pubic bone, and then down, just drop right off the edge of the pubic bone. And so my fingers are right here. Push through the soft tissue, down to the bone, and off of the sacrum. So start with the lateral border of the sacrum, okay? Now you're gonna come lateral and kind of keep walking out until you find the, and then down a little bit, so the ischial tuberosity, yep. And then come just kind of off to the side of that. See how my hand is here? And I can kind of play with it a little bit and feel like, okay, I'm feeling the femur move, lock, and rock.
Mobilizing hand as close to the joint line as possible, okay? So that's going to be in that groin region. I would say, and it also helps with your line of force if my elbow's bent, but I would just say fingers out. So the forearm for this is going to be posterior lateral, okay? Because my joint is like this, right? We already talked about the acetabulum is like this. So I want my line of force not shoving that femur into the acetabulum. I want the acetabulum, or the femoral head gliding in the acetabulum, all right? Is that pressure okay? Sensitive. Okay, all right. Forearm is in line, arms locked. So we're going to bring him into adduction. So around that 60-degree mark is where that piriformis starts to transition from that internal to external rotator. So it's really more of an abductor. It's like 60 degrees. So I'm going to stabilize proximally, so I'm not just pulling him over. Because what I'm trying, this is a provocation test, so I'm trying to stress that piriformis muscle, right? Knees flex to about 90. Maximally adduct the lower extremity. So familiar pain, if that produced familiar pain, that would be a positive test. Okay, and then so this has a fair sensitivity specificity. What are these likelihood ratios? What does that tell us? Moderate shift, yeah, okay. Where are we with negative? Not great, right? It's more in like that slight region. All right, Craig's test. So this is the one where we're looking at that anteversion, retroversion. So is it actually a bony change that's like part of his morphology or not? Okay, so that's what we're trying to figure out with this test. Greater trochanter. I'm going to internally and externally rotate him until I feel the most contact. Like I feel like the greater trochanter is the most prominent. Okay. C is normal, is about 8 to 15 degrees of internal rotation, which would be anteversion, because a little bit of anteversion is normal, right? And actually measure. So we want the wedge stabilizing our acetabulum so that when we glide the femur, we can push through that collagen. Okay? So what I don't want to do, I don't want my wedge in any way to block the femur as I push down. Right? The hardest part is getting the wedge in place. We kind of use the belly button as like a aim. So you're trying to position the wedge somewhat pointed up toward the belly button. Okay. So round about here, okay, but underneath, right? So we're going to do a posterior glide. Okay, thank you. So I'm going to do the similar palpation that we did to find that joint line. So for me, that's greater trochanter, but that could be ischial tube if you guys thought that was helpful. And then I'm just going to come inward. And again, you do have to play around with this a little bit, but I can. And I would say I really want this leg a little bit more relaxed. Okay, so when I push, I feel that tissue going just on the other side of the wedge. So that's good. Line of force is which way? Posterior lateral. How am I doing? Pretty good. Okay, thank you. Okay, so then once I'm there, I don't really need my palpation finger anymore. If I needed to help stabilize, I could do that, but I don't really. Would I hold it? 30 seconds. How many times? 3 to 5. Past it. Yep, you're going to feel like the tissue wants to stop you, and then from there, we're going to push past and hold. And I'd make sure it's comfortable so I'd be checking in. Okay. If you wanted to just do oscillations up until that tissue stopped, just to try to improve that extensibility, that would be a really fair option. And you could do the same thing right here. You don't have to put it right by the ASIS because sometimes that can be a little bit painful, just that pressure of your ASIS right on the wedge. So just know that as you're placing these and kind of figuring it out, it shouldn't really be that uncomfortable. And if it is, just try to move it around slightly, okay? So what I would do is I'd place my wedge, and then I would just do my little joint assessment similar to what we did last time to make sure that you're not being blocked, that you're still getting, because my palpation finger should be under here, right? So if I do my little oscillation, I should still feel that femur moving at your stabilization, and then you're just going to do the sustained hold, okay? Now when we do these in class, we don't always do the sustained hold because we know that there's a consequence to that, so we don't really want to mobilize each other if we don't need it. But you will need to know that for your exam purposes. Okay? This, right? Is that comfortable in your ASIS?
No, actually, it's like
Just inside? Okay, just let me know if that changes. All right, so my direction of force here, into your medial, right? Bring her into a little bit more hip extension if I wanted to, but this is pretty good actually because I can see her like past that. I think we'd start to get, which is pretty good actually. So clearly doesn't need this, but lateral, anterior, inferior, right? Okay, so our line of force needs to be perpendicular to that, right? So if we just do a long leg distraction, that's just going to be more of an inferior glide versus a true joint distraction. Okay?
So what's the purpose of that?
Anterior, right? So which way does this table need to go?
Down.
A little down, right? Because then my line of pull, then you'll see I'll get a little bit more anterior glide. Okay? You want this belt right in the hip crease. So sometimes I'll even ask the patient if they can hold it there. You just hold right there. Yep. If it's uncomfortable, they can put a towel on kind of the inside of their thigh just because you are pulling a little bit. Okay. Now, while I do this, if I just lean backwards, see her leg wants to come with me, okay? So I'm going to provide just a slight counter force. I'm not pushing, I'm just not allowing it to move. This is really easy for the therapist.
Does my leg stay bent this whole time? Like it's supposed to be bent like this whole time?
Mm-hmm. So yeah, I mean, and you could do more of the resting positions if you wanted just a little bit less. And you could do a pillow if they were so that was trouble for them to hold it, which probably in this case would be a good idea, just because if your whole goal is just pain relief. Mm-hmm. Now this you could hold 30 seconds, you could hold a minute. If they were really irritable, maybe you just do like intermittent, where you just pull and then let off.
Can you tell if the patient is like, because like I just realized that I'm like my muscles are kind of like guarded, like it's not letting it distract. So
Okay.
can you tell if the patient's even like getting the distraction, if they're like tensing up?
So you can, sometimes I feel it better, like when I pull I might feel something, when I let go I can really feel it
Go back.
settle back in. I mean, you're always asking the patient, how's this feel?
Mm-hmm.
Does it feel good? But if for whatever reason I thought that you weren't relaxing, or if you're telling me you're not relaxing,
Mm-hmm.
okay, what else can I do to help you relax? So maybe that is pillows.
Mm-hmm.
Maybe I do bring you into a little bit more hip flexion because it's just kind of harder to hold your leg out in that position. I've got this belt around her ASIS, and it's pretty tight. So ideally, I really want to lock down her pelvis as much as possible. Inferior glide that we did before. Okay. We're into a little bit of abduction, we could do that. And I'm just leaning backwards, so my arms aren't doing any work here. Okay? It's very complicated. I'll just use my hands right near the joint line like this, and then I'll just lean my body backwards. So that gets them into a little bit more flexion for glides. That's just an option too. PSIS, ischial tube, greater troch. Okay, so 1, 2, 3. So we're in about there, right? Okay. All right. So first I would assess it in my exam. So how I do that is I usually do a little. Is it a little bit?
A tiny bit, yeah.
Okay. All right. And you can feel it, but just know you have to push pretty hard, right, to get through the glute max. First phase, the muscle pump. You want to be in line with the muscle, so it's not a cross friction. The goal with this soft tissue flow is to try to get that muscle to relax and not guard. Okay, decrease pain. So you want it to be a little rhythmic as you do it. Okay, and you would grade your pressure based on how it feels to them. So if that was too much pressure for her, if you felt her like tensing or you saw her face cringing, that's too much. You passive pumping. So for that, we want to lengthen the muscle. Okay, so we're going to provide pressure and we lengthen the muscle. And as we lengthen, we take off the pressure, okay? So the way that we do that for the piriformis, the hip is in neutral. What's going to be its action?
External rotation.
External rotation. So if we want to lengthen the piriformis,
Internal.
we want to go into internal. Sometimes that gets confusing when you're here, right? But this is internal, right? Okay, okay. So I'm going to provide pressure, move into internal, and as I move in, I'm letting off of my pressure. Okay? Pressure, let off. This is passive, so she's not helping me at all. How long would you do this? A minute or two? Until you feel a tissue change? So once you know what the turgor is, you might feel it start to slowly let go underneath your hand. So ideally that's what's happening over time. Pull into external rotation. I'm still going to provide pressure. So what I say is, okay, you're going to feel me push on the muscle. When you do that, I want you to pull your leg inward. And then as she does, I still let off my pressure. Okay, and then completely relax, I'm going to pull you back. So I give you pressure, pull your leg in, I let off, come back. Okay, okay. And then we would reassess to see how she tolerated that, if we made the change that we wanted to do.